you could imagine these tools fitting into current workflows, whether it's intake tools or helping you write notes, discharge summaries, those sort of things. The other lens you could take, which is the lens that I'd like to take in terms of like my future career, is this is probably an opportunity to use these technologies to reinvent the healthcare system.
Welcome back to another episode of the podcast for doctors by doctors. I'm your host, Dr. Michael Jerkins. Unfortunately, again, absent the one and only Dr. Ned Palmer today, but I am very interested to talk to this guest because it's, of course, a doctor, but a doctor who is on the bleeding edge of research and understanding AI and its application in healthcare specifically. And, of course, everyone's talking about this, especially over the last several weeks. I'm excited to hear his take on the amazing Super Bowl ad wars between GPT and Claude and others. But more importantly, on what is AI's impact on patients, what is AI's impact on doctors, and is all of the anxiety and angst around it worth it? And what are we missing? What should we be thinking about? What is around the corner for both patients and doctors? So without further ado, we'll get to our guest. Today on the podcast for Doctors by Doctors, we are joined by Dr. Peter Brodeur, a current third-year internal medicine resident and rising cardiology fellow at Harvard Medical School's Beth Israel Deaconess Medical Center. He attended the Warren Alpert Medical School of Brown University. Dr. Brodeur's research focuses on human-computer interaction and large language model clinical reasoning. He's a reviewer for Nature Medicine and New England Journal Medicine AI. He also has a master's degree in economics and is a former life sciences strategy consultant. Welcome to the podcast.
Awesome. Thanks for having me. Appreciate it.
That's a lot. So you've done a lot of things. You do a lot of things currently. What is your ultimate goal? So you get done with residency, you go to fellowship. Like, what do you want your life to look like after cardiology fellowship?
As you mentioned, going to cardiology fellowship, definitely want to be an academic clinician. I think as far as my future career, I always want to be a doctor first. That's what we got into medicine for, to practice medicine, take care of patients. And so I'll always have that lens on. But my interests vary widely, as you've already touched on. And, I could put my money down as to what it might be, but it might change. But as far as what I can imagine right now is I really would like to see the implementation of AI into the practice of medicine from an evidence-based standpoint. And so that lends itself to doing a lot of research, which I currently do now, and so hopefully continuing that into the future.
Amazing. Well, congrats on all your success so far. I am very curious, given your different angles you've viewed healthcare, do you think the U.S. healthcare system is actually broken, or is there just some misalignment? I know that's a really simple question to answer, but how do you view it?
Yeah, so I think, when I was a strategy consultant, I definitely got a good lens on the U.S. healthcare system and it's very complex, the different players that are involved. For me, in my previous work, I focused a lot on pricing drugs, and so got a lens into how all of that works, the different relationships, the rebates, the influence of PBMs. And so I think that it's quite a complex environment. I think that as far as whether it's broken or not, I think we're at a crossroads here. And I think this touches a little bit on my interest and hopefully what we'll talk about today, which is how to implement AI in order to maybe fix the healthcare system. And I think people can take one of two views on the implementation of AI. The first being within this healthcare system, whether you think it's broken or not, but you could imagine these tools fitting into current workflows, whether it's intake tools or helping you write notes, discharge summaries, those sort of things. The other lens you could take, which is the lens that I'd like to take in terms of like my future career, is this is probably an opportunity to use these technologies to reinvent the healthcare system, how we actually deliver care to patients, using technologies as an extension of care teams, those sort of models. And so that's sort of, I'll refrain from saying whether it's broken or not broken, but also touch on saying that we have an opportunity here to basically change the entire landscape.
Yeah, it seems like it's easier to spin up and vibe code some sort of AI application that messes with the workflow in a couple of hours. But to your point, the more structural changes are going to take longer and have much greater impact, which is, I saw a headline recently of how AI has maybe decreased burnout in some ways for some physicians on the front lines, especially like in primary care, but it hasn't necessarily decreased the time they're spending on their tasks. Tell me more about how to think about that.
Yeah, so what you're referring to is there's been a couple of studies. The first came out in, I think, JAMA, which really was looking at how scribes change the way that physicians practice medicine and how they feel about how they're practicing medicine. And what I mean by that is, how do they feel subjectively? How do they feel their burnout is changing with the implementation of AI scribes? Do they feel that they're having less time in documentation hours after work? It turns out in that study they did show a subjective improvement, and studies thereafter showed that as well. And the studies thereafter were actually randomized studies. Those came out in the New England Journal of Medicine, NEJM AI, and there were two studies that showed that generally, again, doctors feel that they get subjective benefits from things such as AI scribes, but when it comes to objective measures, it turns out that it saves maybe 20 seconds per note, which is basically on the order of what human scribes are able and capable of doing right now. And so I think that the general takeaway, as you mentioned, is there's a subjective, a feel-good component of it. You know, if you think about the task of writing a note, probably is easier to write it from a reviewer standpoint and change a couple of things than it is to write it de novo from the beginning. And so I think that's probably where the cognitive load is a little bit less. In terms of getting those actual objective improvements, you see companies like Abridge teaming up with different companies to bring in workflow tasks like prior authorizations at the time of the appointment instead of trying to reverse engineer it later after you've already had that clinical encounter. And I think that's where the real money is in terms of improving those objective measures that we hope to see with some of these tools.
So clinically, I practice as a primary care med-peds doctor, and I would argue primary care is maybe one of the hardest jobs in all of healthcare. And one of the difficult things is you have a lot of patients that need a lot of time. Unfortunately, we don't have 27 hours a day or whatever the actual time is to do every recommended preventative screening and or recommendation by USPSTF in a day. So how can these tools actually allow us to spend more time with patients?
What you're seeing now is changing the dynamic of your encounter, which is hopefully with these AI scribes, you're not having your back to a patient or the patient is looking at your shoulder and you're typing. And so that is already in action. There's been several studies looking at clinical intake tools. There was a study out of China just recently within the Nature journals looking at PCP to specialty referrals. They just approached patients in specialty offices and had them use a clinical intake tool and had that AI take a history. Turns out it improves care coordination. It diminishes the time that it takes for that specialty consultant to see that patient. And so those are some of the productivity gains that you're seeing. I think as far as the future and the PCP's role, you know, you can imagine, as you alluded to, the time that it takes to get through all those different, USPF with the primary care, all of the guidelines that you have to follow. I myself, as an internal medicine resident, currently practice primary care here at the medical center. And so where I see some of this productivity gain is really AI as an extension of the care team, right? And so taking care of some of those things that maybe will off-burden the physician. You've seen things like the state of Utah team up with a company called Doctronic to do prescription renewals, right? Sometimes you get something in your inbox where you're like, this probably isn't at the top of my license and it's taking 5 minutes for me to figure out whether their LFTs were off and should I re-prescribe this statin or not. And probably that could be, it's quite rudimentary, could be off-shelf to an AI tool. And so those are some of the things that I see going forward as AI as an extension of the care team, helping you fill in the gaps where you're not available 24/7.
I want to talk more about Doctronic. I'm really excited about this topic. And I might butcher this, but so Doctronic is in the state of Utah. It's this pilot, as I understand it, that allows an AI tool to automate refill requests for patients who have been on a medicine for a long amount of time. I can't remember how long, who basically have been stable and have met some certain criteria, and it's rolling out, right? So there's two reactions I saw. There was one is, how dare you? This is really crossing the line. This is not appropriate. And there's others that say, this is just the beginning. This is great. Bring it on. That way I can do more clinical time, spend more clinical time with my patients. Is that your read too of how people have reacted to that?
It strikes a chord from a regulatory standpoint, I think. Traditionally, states have been in charge of licensing and how medicine is practiced. The federal government and the FDA has generally been in charge of medical devices used in the practice of medicine. And now with Doctronic, we're seeing a medical device that practices medicine. Whose jurisdiction does that fall under? It's unsure at the time. And so I think that is one thing that people have sort of different opinions on. As far as the implementation of it, I'm sure that, I don't know everything about how they're designing it, but I'm sure they're going to do it in a very safe way, use medicines that generally aren't high risk, like controlled substances. And so I think that they have a good opportunity to show the utility of tools like this. And I see it as, and one of the arguments they've made in some of the press releases I've seen is that there's this whole, it also touches the topic of, will AI replace doctors? Because now, it's doing a prescription refill that generally was only a task beholden to doctors before this. I think the argument they've made is that, look, we have a shortage of certainly primary care doctors. This is just filling in the gaps in the short term at the very least. And so I think from that standpoint, that's the argument that they're making, how this is currently a value add to the healthcare system.
Totally. For those in primary care who also are supervising nurse practitioners and PAs and have to sign off on their refills of, say, controlled substances or others, let's just say not even controlled substances. Let's say you're at a clinic and you manage and oversee 3 nurse practitioners and everyone has a full patient panel. And one of those nurse practitioners leaves. All of a sudden, for the next 6 months or whatever, you're now refilling all of their refills by hand or on Epic or some EMR. The amount of times I was talking to a partner and he basically said, and this happened, there's actually 2 nurse practitioners that left. And he said he got over 100 refill requests a day from those 2 other providers' patients. Meanwhile, he's seeing 25 patients a day himself and doing his own refills. Like, that's great. Bring on Doctronic. That would be awesome. I totally understand the use case. I think everyone it's the slippery slope paranoia. Like, where does it stop?
Yeah, I think that gets at kind of this safety oversight aspect of it. And I think as we invite some of these technologies, and as they're in their infancy and getting into real clinical workflows, I think that it's going to be, I'll say, a little bit painful in terms of figuring out how safe they actually are, because one of the things that the AI community harps on, at least from a clinical perspective in terms of safety, is that human oversight is generally the only way that we're going to figure out whether this is safe. And so I think unfortunately, as hard as it is to say, when we deploy these products, we're going to probably have to have what we call as a human in the loop the entire time, meaning every piece of information that goes through an AI also goes through a human physician. And that's very labor intensive, but also I would argue quite necessary in order to figure out if what we're actually doing and implementing is safe for patients. Because at the end of the day, I think all doctors can agree that the only thing that we want to see AI do is really improve patient outcomes, and as well as improve our own lives. But we went into medicine to improve patient lives. And so I hope that, the first tenet, core ethics of medicine is to do no harm. And so getting that right, I think, is extremely important as we deploy these technologies.
I totally agree with that. And speaking of harm, how should doctors think about the liability of these AI tools in them making mistakes? And my understanding is Doctronic was able to score some sort of insurance to at least shore up some of their risk. How do I think about liability in the case of AI application to clinical delivery of care?
I'll bring up a case that I had in medical school as an example. This was way before AI was ever implemented into any healthcare workflows. I remember a co-medical student of mine who saw a patient, and you know how we sign our notes in the chart and an attending attests them as a progress note. So to show off their knowledge, they saw a patient and included a differential of like 30 different things. And within that was a zebra diagnosis that the patient actually had and was misdiagnosed, and ended up being a litigation issue later down the road because, hey, that was charted, why didn't you, attending physician, consider this in your differential? As I think forward in terms of AI doing that, one of the challenges of AI is it's actually, if you've used the systems, they're quite verbose. They put out differentials that are quite long, and so you can imagine once that's integrated into a chart and that's in a patient chart, I think the physician will have some liability to what the AI is saying. I think in the near term, just as we radiologists don't get into litigation because the CT scanner was bad, right? Or the CT scanner made an error. The same way I think that AI will be parallel to that. We're going to still be liable, I think, at least in the near future.
I mean, the biggest use I see, at least of practicing clinicians, is in the tools that help basically with referencing and information gathering, like open evidence, like Doximity's model, like I think UpToDate has one. I couldn't afford the subscription anymore. But and now, right, it's there's more direct to consumer models with GPT Health and Claude for healthcare. Like, what models do you see out there that doctors use, especially, and I guess let's just take your hospital as an example, that doctors use, and how effective is it at influencing and improving care?
The first thing I'll say is I don't endorse the use of patient data in these systems. I would tell folks to refrain from doing that. These aren't HIPAA compliant environments, and so from that standpoint, you really shouldn't be putting private patient information into those systems. But to the extent that you're providing it, say, hypothetical information or a small question about your patient that you might have for open evidence, hey, what's the evidence of, which medicines should I start first on a patient with HFrEF, which GDMT arm? Those questions you can put into open evidence and get quite a good answer and references to guidelines. And so, if you were to come to our hospital and see our internal medicine admitting room, we have two screens. One of them is Epic. The other one is something like open evidence. Probably in previous times it was UpToDate, but it's variable now. You see folks getting information quicker with systems like UpToDate, open evidence, whereas UpToDate is very static. It's sometimes overwhelming to pull up an UpToDate article, and it's super long, and you go down to the summary and recommendation, and it doesn't have exactly what you're looking for. And so I think in today's time, just the ability to get a tailored answer to what you're actually asking is a little bit different in previous times with something like UpToDate. And then ChatGPT, I think I'll share the way that I use it, which is I generally try to think first as a doctor, come up with my assessment and plan, come up with my differential, and maybe, again, not using patient information, sort of creating a hypothetical case, putting it into ChatGPT, and seeing if it can elicit something that reminds me of something that I should have considered as like a second opinion sort of situation. And I think that's where some folks are really finding it useful. And we can get into, what is human-computer interaction and that entire field, which is in and of itself an entire discussion. But that's where I see some folks using it.
What's funny is even before UpToDate, it was Hippocrates, and then there's always another resource that someone's taking the place of becoming more efficient at. I am curious on. You mentioned how you use open evidence. Are you finding that your patients are also coming in having used some of these direct-to-consumer models and asking you questions from it?
Yeah, so I think that, talking about the concept of patient-facing AI, I'm a big proponent of patients coming in and asking questions that they have about their disease process from a deeper perspective. And I think that's what these tools allow. They allow patients to take ownership of their own condition, and I think in some ways provides more engagement with their condition because they're able to get answers. I'm sure we've both had that experience where you see a physician, oh shoot, I should have asked that, on the way home, and you can just put that into ChatGPT and get some sort of answer from it. And now with the advent of GPT Health that they have, they're sort of endorsing that sort of concept that you can do that. I will say that there have been studies with patient-facing AI. One study out of, again, New England Journal of Medicine, NEJM AI, that showed that patients, whether they get bad advice from a large language model or good advice from a large language model, and they even blinded patients to whether it was an LLM or a doctor typing back to them, patients can't tell. And so we have to be cautious that patients can assume we can assume that patients can't play any oversight role in this process. And so we have to make sure that some of these systems are safe, and you can make an argument that maybe some of these products are a little bit premature being marketed as health products and able to answer your questions urgently, things like that. But again, speaking to the fact that patients coming in with better questions, we can get to a much deeper understanding and a plan together than we could if I'm just asking things about answering questions about medication side effects or something that they could figure out beforehand on their own. Whereas maybe we have a deeper discussion talking about the differences between two meds, not just the side effects of one. So those sort of things.
Totally. Is there evidence yet, and I know there's been lots of studies, so I'd love your summary, that doctors are getting worse clinically with our clinical skills through use of AI?
Yeah, so two topics related to that. The first is something called automation bias. And that's when doctors generally just sort of forget their own thought process, adopt the AI, and run with it, right? And we know that from studies that that does happen to doctors. There was a particular study where they had doctors perform diagnostic reasoning and create a differential, and the researchers actually put in wrong diagnostic reasoning traces into some of the outputs that the doctors were getting. And it turns out when you compare them, the two, with doctors using actual LLMs with real answers versus the ones with false reasoning traces, the performance drops. So that we are accustomed and we are able to see some automation bias with doctors, and so we should be careful with that. The second topic, which I think you're referring to, is deskilling. Now, whether deskilling is good or bad, I think is a debate. You can probably argue that there's some tasks where you're okay with giving them up, but I would make the parallel, the parallel argument of GPSs, right? 20 years ago, probably everyone knew how to get somewhere, but nowadays, I probably couldn't get to the supermarket 2 miles from here without a GPS. And so that just is a great example of deskilling. There have been studies looking at, particularly in endoscopy and GI, looking at adenoma detection rates. They looked at the rate before AI was implemented and then after AI was implemented and used the arms that didn't use AI, but in the second half, they had been exposed to AI but just weren't using it in some of their cases. And it did show that there was actually like a 6% reduction in the absolute detection rate of adenomas. And so that is something we should all be careful of as well. There's certainly a doctor and human side of the human-computer interaction. It's not just about optimizing what model output is.
Are you worried about deskilling further the physician workforce?
From my standpoint, I would say less so on current attending physicians. I would say much more worried about the next wave of physicians who are exposed to these products. With all like the social media, our attention span is so little now. I'm a little bit worried about that automation bias because it does provide a real shortcut where, if you just put everything that's a difficult case for you into ChatGPT, it gives you an answer and you run with it. Did you really learn anything from that situation? You can imagine, some of the smartest doctors I come across are PCPs and internists who have a really high threshold to consult other services. And it's because they take that extra length, that challenge to try and figure out what's going on by themselves rather than relying on a consultant the entire time. And so if we have medical students coming up through the ranks who are learning on these tools and just using ChatGPT for every single case that's difficult, you can imagine how their clinical reasoning skills might be blunted 10 years from now. And so that worries me a little bit.
Walk me through the head-to-head studies there have been. I know they're limited on clinical, like diagnostic accuracy of AI plus human on their own. How should I think about it? Because there's been lots of those, but walk me through the summary if there is one.
Certainly. So there's two ways that we generally study this. The first is going to be diagnostic reasoning. The second is going to be management reasoning. And the reason why we separate those two topics is management reasoning is a little bit more nuanced. You can imagine a type 2 diabetic where two physicians will manage it completely differently, but still sort of correctly. Whereas diagnostic reasoning, whether they have diabetes or not, tends to be a more binary outcome, right? So those are a little bit different of sort of reasoning skills. As far as management reasoning, we did see in trials a study in Nature Medicine looking at physicians with GPT-4 versus physicians with conventional resources, and we did see that signal that physicians in GPT-4 outperformed the physician group with traditional resources like UpToDate. They did the same exact study, but from a diagnostic reasoning standpoint. This is a group out of Stanford. And we didn't see that signal. And so that started to raise questions about, is there some way that we can modify the human computer interaction to get a better outcome? You would want the situation where you could get the summation of the two, the human ability plus the AI ability. I know when I'm wrong, I know when AI is wrong, and we can complement each other. But that really wasn't true in the literature. And so people have tried to modulate the way that human and computers interact, where GPT-4 might produce a more critical, the human goes first, GPT-4 provides a critical assessment of what the reasoning trace was. When a study used that, the same group out of Stanford, we did see that signal that we expected to see. So there are some ways to modulate the interaction where you're able to get to a better place than just humans alone. Now, the other aspect of this, which I think is very interesting, is the fundamental theorem of informatics. And what that says is that humans plus machines will outperform machines alone or humans alone. And that's like what we hope to get out of this. Now, in these studies that I just referenced to with management reasoning, humans and GPT-4 versus humans and conventional resources versus GPT-4 alone, it doesn't necessarily turn out to be true that we outperform the models alone. So for some reason, humans and models can't outperform models alone. And so that sort of violates the fundamental theorem of informatics. And so hopefully, with the research that I do a lot is modulating those interactions to be able to get to a more complementary state.
What are some of those modulating factors you're changing that puts us closer to models plus humans actually being the best combination?
So I don't know the answer yet, and that's why we spend a lot of time trying to figure this out. The reason why that is because we as physicians, especially coming from your standpoint, PCPs, there's already an enormous rate of burnout, right? If you're just adding in another piece into the EMR that's going to give you alert fatigue, or it's going to make you use something outside of the EMR to try and get a different answer, create a different differential, you can imagine that's just adding way too much. There has to be a better way, and a way that is acceptable to introduce these technologies into the fold so that we don't inadvertently increase the burnout rate. And so I think a lot of people are interested in when is the right time to interrupt a doctor if you're using clinical decision support. Is it after they document their history and physical? Is it after they've created their differential? Is it, a big study last year in Penda Health with OpenAI? They had something running in the background and provided stoplights to a doctor when the AI thought that the physician's reasoning was off, or some documentation was off, or the differential was off. And so that's been a big topic of discussion, is where do you interrupt a doctor, when along the way in terms of the clinical interaction, if at all. And so that is something that I'm particularly interested in.
Is there a part of the typical outpatient or inpatient patient visit that you think AI will make obsolete?
I think that AI is probably pretty good at history taking at this point. Google has a lot of tools. There are studies out of the K Health system, a telehealth system, that I think, pre-intake history taking is something that's going to be a little bit obsolete in terms of like being able to triage, I think, going forward. These models are pretty good at taking a history and providing information to doctors that they can then interact with. So I think that's one of them. Things that are already becoming obsolete is note writing in terms of ambient scribes. I hope to see a lot of the administration and workflow tasks de-escalated from physicians. Things like discharge summaries. You're already seeing some of that integrated into healthcare systems. So I think some of those burdensome things that require I would say text-based tasks. These models are particularly good at communicating and creating text. And so anything that you can imagine that is really like text heavy, these models are quite good at those.
It's really interesting. I agree with all of that. But on the other hand, I think to myself, especially in the outpatient setting, I'm just thinking about primary care, is a lot of the delivery of care is based on a relationship between two human beings. And it's interesting if you take away the history altogether and you jump right in. It's like going on a date, except you skip the first 3 dates and you start talking about like getting engaged or something. And you're like, wait, whoa, we got to like establish some rapport. I got to get to know you. You got to get to know me. And if I jump right in and say, I think we need an MRI because of your headache severity, based on you just talked to, there's how do we balance the humanness of those outpatient interactions if we just totally make the history taken obsolete? I agree. It seems like a task that AI could do. I just wonder what is the most effective way to deliver care with that.
I'll caveat and say that that's not something that's currently implemented into practice. There are no like specific AI intake tools. I just see that as a signal in research right now that might be something that AI can overtake in the future. The flip side to what you mentioned is, saying, oh, I saw that you described that you have, rhinorrhea with your headaches. What can you tell me a little bit more about that? You can have a deeper discussion. Just then, like, tell me about your symptoms, and that takes 5 minutes out of the visit, out of your already busy day. And so I think that again, getting it right is going to be something that is going to have to be borne out in the literature, and again, with human oversight and a big labor-intensive effort. I would also say that, perhaps in terms of relationship building, I do see that as an issue with AI going forward. I think that AI can certainly be an extension of the care team, but I will say that personally feel that, and hopefully this makes doctors feel good, is that I don't think that AI will replace doctors for that specific reason. And I'll say that I think patients may think that they want the convenience of seeing a doctor from home in the form of AI, but when it comes down to it, I feel like a lot of the practice of medicine is the fact that you're telling another human being how you feel, and that human being can relate to you. And we can have a discussion about that. I can imagine how somebody feels when they have a certain condition. And so I think that provides something comforting to patients that I don't think that AI will ever be able to replace in terms of the interaction.
Yeah, it's a deeply human experience. And you're seeing a little bit of it, I would guess, in just how accessible we are making clinical direct to consumer clinical services, lab services, or some of these online like pharmacies that make care, I guess, in some way accessible with cutting out so much of the human interaction. But what I see is anecdotally, and I think there is some data to support this, is that it actually drives more people to use the health system because they get a bunch of information that they're not sure what to do with, and they can't access someone they can feel understands and can give them answers. So then they come to see me and show me the 400 lab results they got from one of these online, labs. Do you see that too?
Where my mind goes with that is sort of patient expectation setting. I can imagine a world in which you have these AI systems saying, like, in response to somebody saying that they have a headache, you need to get a stat CT head, right? And they come to you and say, I need a CT head like right now. Like I've had a headache for 2 days, and it's you can probably de-escalate that situation, but you might see some friction in terms of AI creating expectations that the healthcare system just can't tolerate at the moment. And that for whatever reason, you can get into the cost of it and just the implications that it has of the resources that are available. That's one thing that, because we have these two siloed environments right now, you have AI that has no context of the healthcare system, no context of your particular practice, no context of the relationship you have with your patient, but it's making recommendations maybe that you can't fulfill for that patient. And so I think that's where it's going to be a little bit challenging when we invite these systems, and I say as part of our team, to make sure that it's not escalating the expectations that our patients have of us. Of course, if somebody needs a scan, you want to get that to them, but you also want to avoid the situation where you're just overburdening the healthcare system.
Yep. I want to switch gears just for a minute because we do have dental listeners as well, and we've left them out a little bit, and our veterinary friends. Do you see any real impactful applications of AI in the clinical decision making for our dental colleagues?
It's out of my realm, but as a journal reviewer, I have reviewed articles in that area where I have reviewed it. I'm trying to remember the topic. It was in radiology, looking at enamel erosion in some dental condition, and whether it was able to augment physician decision making in terms of some sort of procedure. This was a while ago that I reviewed it, so it's difficult for me to remember. But you can imagine those use cases, that radiology is quite a big use case across the board, whether it's dentistry, veterinary care, human medicine, folks and internal medicine and different specialties. So that's one use case where I think it's kind of unanimous across the board, where imaging is sort of relevant to each one of these specific fields, and something that I've seen and personally reviewed in journal articles.
Makes sense. I've talked to some of my dental friends and colleagues about, open evidence, and there's really not or the equivalent, tools. There's really not one that appeals to dentists yet that I know of an up-to-date or whatever a version for dental colleagues. But they have tons of academic research and recommendations that are changing. I know there's a lot of variability between potential practitioners out in the field and their own private practice, but as far as evidence-based dentistry goes, it's interesting to me that I don't see a standout tool there, at least yet, until someone listens to this and then goes and makes it.
Yeah. I think maybe that has to do with the biggest impact, dentistry is obviously a huge field and everyone has teeth. But as far as the wide variety of conditions that you have, I think that, I'll say that I also see this as a signal within medicine, in that surgery tends to lag behind in terms of research within AI. Certain fields, certain subspecialties generally lag a little bit behind. And that's probably because internal medicine generally leads the force because we cover the widest variety of conditions. And so we probably as a specialty need the most clinical decision support, and folks are interested in using those tools because a lot of questions, somebody who comes into your office may or may not have a subspecialty question. So you see those patients, whereas subspecialists tend to really probably not need as much clinical decision support at times. And so maybe that's the signal that we're seeing. I'm not quite sure.
And the documentation piece, right? I mean, as members of my family who may or may not be listening that are surgical subspecialists, joke is that us internists judge our quality of work by how long our notes are, which may be changing. And so our surgeon friends, they don't write long notes. I still can't even understand ophthalmology's notes. It's a different language. And so that's probably part of it too, of there's not that much this can help me with on the scribe piece, or like you said, the clinical decision making, because subspecialists, have more narrow and deeper focus. And I think that I wonder, you've already mentioned this about learners. How are learners applying this? We talked about what is potentially going to be obsolete in our clinical encounters. What do you think AI makes obsolete for our medical education system?
There have been studies that have already looked at student sentiment in terms of going to lecture or learning from textbooks versus learning with LLMs. Not that medical students go to lecture anymore. That's been the case for quite a while. So that probably was an obvious signal that we could predict. But students do enjoy learning from these tools because there's that interaction piece to it. There's that asynchronicity to it where they can access it at any time. This gets at the way that clinical reasoning is taught in medical school. And I think that medical educators should be a little bit skeptical at AI, but also make sure that they're integrating it and how it's used properly in the reasoning process. For the reasons we already mentioned, you don't want to take shortcuts for every single challenging case you have. And I think medical education students already have a little bit of an issue of focusing a lot on board exams and multiple choice questions, which turns out to, even true for large language models, to not correlate well with real practice of medicine in open-ended fashion. And so I think what's referred to as the multiple biopsy approach, which is you have your simulated sessions of the OSCE settings, you have your multiple choice questions, maybe script concordance testing, those sort of things, and then you have real clerkships where you're integrating students and looking at their reasoning with notes. Within that, I think medical educators should take the opportunity to integrate AI into that multiple biopsy approach and start to, instead of being reactionary to AI, start to be proactive and integrate it into clinical reasoning education.
That makes a lot of sense. I think that it's already a lot different from when I was in school, which is not that long ago, of how students learn. I'll be interested to see over time how those, you already mentioned this, of clinical reasoning, if that does deteriorate, or maybe it's better because they have more potential reps with simulated patient cases in ways that we maybe didn't have access to, more robust OSCEs, et cetera. We go through a rapid fire here in a second, but I have one question before we do that, which is, What is an application of this that most people aren't expecting that you're seeing? You see all these papers submitted, you're reviewing, you're seeing all the latest research. What's something that most of us aren't seeing but actually is closer than we think?
A lot of what I'm seeing, we can talk ad nauseum, and we have, about like clinical decision support and diagnostic reasoning, management reasoning. The coolest things that I'm seeing now are using models for risk stratification. That turns out to be quite interesting. There's many studies that have these big multimodal models that can read echoes, that can read CT scans and come up with multiple different diagnoses. And then at the end of it, it's like, oh, by the way, this also helps us predict who responds to certain treatment or who has recurrence of cancer. Epic, their model called Comet, basically, instead of, this is very technical, but instead of using tokens and pieces of words, tokens as pieces of words, which large language models use today to predict the next word in a sentence, they tokenized medical events. They have obviously Epic has a huge database of medical data, and they tokenized medical events and medical timelines. And they were able to create these highly accurate, I would say, next medical event generators. And so I think risk stratification is really going to be revolutionized, and that gets at personalized medicine. And so I think that's going to be another next wave that we see as these models. They're trained on a ton of data. They have such abilities in terms of predictive abilities, which typically in previous times wasn't that interesting. You have sepsis predictors. There's tons of sepsis predictors. We generally don't really use them. But I would say when these models get so good, it's probably going to be something that we can't really ignore in terms of helping us make decisions about maybe who to screen for something or which treatment to use.
It's essential. And it'll be interesting to see then how that affects the screening guidelines, and it'll be probably way more personalized instead of the broad brushstrokes.
Yeah, as far as screening, it's been interesting. A study that was last year, that was a huge study in mammography reading with hundreds of thousands of women. We did see a signal where radiologists had the opportunity to review a safety net AI read when they read it as normal and AI thought it was suspicious, increased the breast cancer detection rate, and importantly, relevant to folks like us, it didn't increase the false positive rate in terms of biopsies when women came back. And so we're seeing that signal where we can be more accurate when we're recalling women instead of just recalling a bunch of folks and still having that issue of subjecting people to unnecessary biopsies.
Yeah, that is super interesting. There's it's gonna be interesting too, because you have the large EMRs, or the folks who have all of the data, of course, will then have the superior models of prediction, which will then, in some ways increase their moat from a business perspective and use case, which is a little gross to talk about. But I want to go through a rapid fire. So I say a statement and you tell me if you think it's true or false, and then we'll wrap it up. This has been great. But I'll go with my first statement. True or false? Medical training will be shortened because of AI's effect on education.
I would say right now, false. If I was a betting person, I would still want doctors to be taught how to reason and not take any shortcuts. I think that gets at the point of deskilling, where I wouldn't necessarily want, just because AI is in the fold, that doctors now can have shorter training time, less knowledge than they typically did in the past. I would still want doctors to be able, into the future, to be able to practice autonomously to the extent that they can. And so I wouldn't necessarily want to use AI as a crutch to say that we can shorten training. Now, training is long enough, and you can make an argument that maybe even today's day that some training should be shorter, and we're seeing a lot of arguments for that. But I don't think here and now that AI is good enough to say that we can shorten training.
I tend to agree with that. Not that this is part of the podcast. It's actually what your opinion is, not mine. All right, so next, true or false, doctors will see more patients a day in 5 years because of AI and technological advances.
I think probably true. I think we've seen some of that, like I mentioned, with those tools, particularly that's the recent study in January out of China that showed that specialty intake tool was able to generate faster consultations. And so that naturally opens the door to the ability to see more patients. I don't think that they saw that signal in the study, but you can imagine a world in which you could see that it increases efficiency so much that you might have extra room for one more patient. I hope for our sake that doesn't take a hold and increase our burnout, because you can imagine if a situation in which AI screens out all the easy cases and is able to take those URIs that you see in the clinic that you typically use as a breather. Oh, and then it turns out that all you see is challenging cases all day long, right? That might be an issue going forward.
True or false? Elon Musk was right, and that people should not go to med school.
That is false.
I think I knew the answer, but I had to ask. Why do you say it's false? I mean, you've already hit on all this stuff. I don't want to make you repeat all your talking points, but
Just for the human aspect of it alone. I mean, it's such a blessing to be able to treat patients and have an interaction with them that's so close, heart to heart. I think that there's no chance that AI is really ever going to replace that feeling that you and I get when we're able to help a patient through a difficult time. I think for that reason alone, I would go to med school again. And of course, we love the science aspect of it and the thought process and the detective work. I mean, that's why I went into internal medicine. So I think that if you still love those sort of things, that regardless if there's an AI that can do it better than you should still follow your passion.
agree. All right, I'm going to say a few things. I want you to tell me if you feel like before the end of your lifetime you would feel confident doing. So one, do you feel confident by the end of your life you probably already have, ride in a self-driving car?
I actually have not done that yet, but I would really like to do that.
Okay, but you feel confident right now.
I feel confident. I've heard enough from folks that they enjoy the experience, and I would like to do that. Yeah, I'd feel confident.
Do you feel confident by the end of your lifetime that you would and be comfortable receiving refills from an autonomous AI agent?
Yes, I would definitely feel comfortable with that.
Do you think by the end of your lifetime you will feel confident that you could have a wound sutured by an autonomous surgical robot?
I think probably, yeah. I don't know as much about that field, but I can imagine definitely. I've seen robots perform like carotid ultrasounds pretty better than humans, so they definitely have some fine motor skills.
Okay. Last one. Do you think by the end of your life you will feel confident in receiving a diagnosis from an autonomous AI model without a human in the loop?
Yes, I would feel confident with that. Barring that, I don't know the answer to which conditions those will be yet, but I think that's something, as I mentioned, with tons of human oversight, eventually we're going to be able to delineate which cases should be autonomously managed by AI and which cases should be shelved to humans.
Okay, very interesting. I will close with our last question. We ask every guest, what is one thing that you've recently changed your mind about?
I'll give you two answers. The first is a very resident answer, in that you don't need 8 hours of sleep a night to operate effectively during the day.
You need 9. Is that what you're saying?
Yeah, maybe, yeah. But as you and I know, residency pushes you to the limits, and we've talked so much about AI, but there's so much to say about human abilities, what we're able to do on little sleep, how we're able to react to changing information right in front of us. We do some things like that better than AI, and so I think one thing I've realized is I don't need quite as much sleep as I thought I did.
What's the amount of sleep that's ideal for a resident?
Ooh, I'd like to hear your answer on that. I would say I feel good if I'm getting 6, I would say.
I think 6 is the most realistic, optimal answer, in my opinion.
We've both had nights, definitely, where we've been awake for greater than 24 hours.
Absolutely. But you had 2, so that's one thing you changed your mind about. What's the second one?
Second one is very scientific. There is this concept in artificial intelligence called AGI, artificial general intelligence, and super intelligence. And you'll hear so many folks talk about that, the CEOs of the frontier labs getting up there and talking about when we're going to reach AGI or super intelligence. And I recently read a Nature review, an editorial actually, that claimed that we have reached AGI. And so I've sort of changed my mind a little bit about that. It depends on how you define it, AGI, whether it's models performing at expert level in every single facet of knowledge, right? Which is in this case, they argued, really not representative of human language, right? And just because models are getting better and better every single year doesn't necessarily mean that we should change the definition of what general intelligence is. Maybe it's just being able to swiftly move from certain content from other certain contents and perform at the level of a basic human. I think this also gets at the fact that some people feel maybe this is a huge topic, but evolutionarily uncomfortable with the fact that we may not be, have in the universe the most intelligent mind. Perhaps there's another on the rise sort of alien intelligence, and maybe that's why we keep changing the definition. No, it's not at our level yet. We should, it's not at AGI, but perhaps I've changed.
Wow, that's a whole other podcast. I'm really sad we didn't spend more time on that.
Yeah.
It is interesting, though. It's kind of like Medicare for all or something. That's like, what does that actually mean? And what are you advocating for? AGI, what does it mean? What are you advocating for? Are we moving the goalposts? It's hard for me as a non-technologist to really understand that.
Ultimately, it doesn't matter that much. Ultimately, I think what you and I care about, same thing that in terms of calculators. I myself study AI. I don't really necessarily care what's underneath it, as long as it's reliable and it works. As long as that calculator provides me a reliable and safe outcome that I can then use to improve my patient outcomes. That's what I care about at the end of the day. So whether we have or haven't reached AGI, it really doesn't matter all that much, as long as at the end of the day, patient outcomes are improved.
Absolutely. Did you like all the AI commercial battles in the Super Bowl?
Yeah, it's interesting. Obviously, there's the big three labs, and everyone is trying to vouch, and they all have different benefits and drawbacks. And I would say basically the way that I think about it now is they're all basic parity at this point. Whether you use Anthropic or ChatGPT or Gemini, whatever you feel most comfortable with at this moment. I wouldn't necessarily endorse one over the other.
Even though some had better commercials. I agree.
You'll notice some of them have quite poor marketing in terms of naming of their models. It's whether it's version 2 or 3.5 or this, who comes up with these? But I guess they make good commercials.
Agreed. Well, where can more people find your research or follow all of the work that you do online?
So I'm a part of the Arise Network, which is a Stanford-Harvard collaboration. We recently put out, I authored with some other folks, Ethan Go, Dr. Jonathan Chen, Dr. Ethan Go, Dr. Jonathan Chen, and Dr. Adam Rodman. Dr. Rodman and I work at Beth Israel, Dr. Go and Dr. Chen work at Stanford. We study human-computer interaction. We have our own website. You can go read a State of Clinical AI report where we reviewed over 100 studies over the last year, looking at all these topics that I touched on today, whether you like scribes or human-computer interaction or medical event prediction models. And so we have our own website, and you can just Google that, the Arise Network, or Google State of Clinical AI 2026, and you can follow along. We post all our research there, and hopefully a lot of things coming out this year.
Very cool. Well, Dr. Brodeur, thanks for your time. Thanks for joining me. This was awesome.
This was great. Thanks for having me.
Thanks for joining us this episode, and you can catch the podcast for Doctors by Doctors on Apple, Spotify, YouTube, and all the other major podcasting platforms. If you enjoyed this episode or learned anything here today, please take a moment to give us a rating and subscribe so that you don't miss a single episode release. To submit topic suggestions or guest suggestions or questions, you can reach us at podcast@panaceafinancial.com. As always, thanks for listening, and the next time you see a doctor, maybe you should prescribe them this podcast. See you next time.